Chapter 13, Chemical Dependency and Co-occurring Conditions. Now, when we are looking at co-occurring conditions, we have to look at, especially when we look at substance abuse, the nature and intensity of the drug use. So the type of drugs they're using, how often they're using, and also the effects that the drugs are having on them, or whatever the substances are. Substance abuse may have a comorbidity with other disorders, so we have to figure out which came first. If a client has bipolar disorder, as well as a substance abuse such as a cocaine addiction, we have to kind of figure out which one might have came first. Now, what's important is that either way, we do need to treat both of the disorders, but it will kind of give an indicator that is it that because of the client really it's the disorder, maybe a depression, the bipolar, as well as maybe psychosis is what's causing them to use drugs, then perhaps through medication treatment as well as counseling, then that substance abuse may subside. But if the client has already had, substance abuse, and then following that is a disorder, then of course we're looking at first and foremost treating that substance abuse as well as secondary treating the mental disorder. So it just kind of gives you an idea of which way to go. But either way, even if there's a comorbidity, you are treating both disorders. But it will kind of give you an idea of which came first. Treatment is based on the nature and intensity of the presenting problem. So that's when we're looking, once again, going back to the top slide, the nature and intensity of the drug use. And this is going to play a part in our treatment plan, because something we may have to consider is that before the client can get treated, they may have to go through detox. Now we are assessing, looking at treatment and goals for these co-occurring disorders. There are various screening and inventories or assessments that can be used. For one example, if you look on page 95, there is a CAGE questionnaire that can be administered in counseling, just to give us an idea of the nature, the frequency, the intensity of the drug use. And some of the questions are within the CAGE: have you ever felt that you should cut down on your drinking? That's the first question. The second question: have people annoyed you by criticizing your drinking or drug use? Third, have you ever felt bad or guilty about your drinking or drug use? And the final question is: have you ever had a drink or used drugs first thing in the morning as an eye opener to steady your nerves or to get rid of the hangover? So the acronym CAGE comes from the cut down, annoyed, guilty, and the eye opener. So these questions will give us ideas of, like I said, the nature and intensity of their drug use. But then we have to look at with treatment that there are various phases to the treatment. And the phase 1 is a complete assessment. And of course, we're going to do a thorough background interview, like I said, if there's any records, observations, anything that can give us as much information about our client as possible. So definitely a complete, thorough assessment. Also, we would like to look at, even within a situation or even within assessment, is the current situation that the client is going through. So get as much information about currently their life situation, so they're living with what's going on if they at the job, if they have a job, friends, family. So all of these things are going to play a part. If possible, if you can interview family members, spouses, friends, partners, that will also be beneficial so that you can get their point of view of the possible issue or what they have observed. And of course, we would need a consent to talk to anyone outside of our client. If we look at phase 2, is determining special needs of a duly diagnosed client. So we're looking at and things that we are questions that we might need to ask is that the client, do they need a detox, a supervised detox? We might also wonder, do they need psychotropic medications or a psychiatric evaluation? Will our client need inpatient observation based on their behaviors or threats? What is their level of resistance? What is their potential for relapse? And finally, what if any, environmental issues that could affect treatment? Child care, work, finances, spouse, codependency, enabling issues, because all this is going to play a part in the overall treatment and outcome when it comes to our client. The third phase, and which is the consideration of appropriate medications, is something else that we will look into. And although this may not be, in a sense, our expertise when it comes to prescribing the medication, this thorough assessment, as well as the phase 1 and 2 are very important, because if we are able to collaborate with their psychiatrist, of course with their consent, or their physician, this can be very beneficial to the overall client's recovery, and as well as prevention of relapse, because it's almost like a multidisciplinary team that's getting together to come up with the best treatment plan. So now let's look at medications. Depending on the dependency, and we will see that there are some medications that can be used for different dependencies. So when we look at alcohol dependency, there are various drugs that can be used, and based on these drugs, it depends on what the overall outcome is. Or I should say, let me say that in a different way, the desired outcome. So the first one we see is disulfiram, or we might really know it as a trade name Antabuse. And this produces a very unpleasant reaction that may include flushing, nausea, palpitations if the client drinks alcohol. So the key is they will take the Antabuse, which is usually in a pill form, and if they consume alcohol, these are the negative aversive effects they will feel, which of course is going to hopefully deter them from drinking. Who wants to take a pill? Of course, because that's what their intervention is for not drinking. But then as soon as you take a drink, you're vomiting and you're having all these physiological symptoms. Compliance can be a problem with taking this medication, but among the clients who are highly motivated, this can be very effective. Naltrexone, or we might call it Rivia, blocks the opioid receptors that are involved in the rewarding effect of drinking and in the craving for alcohol. So it reduces relapse and heavy drinking, and it can be highly effective with clients. If we are not getting that pleasurable reward feeling when we are drinking, as well as that craving of, oh, I like another glass and another glass, then what's the point of drinking? Most times, and many of us who do not have an alcohol dependency, we usually drink to get that pleasurable feeling. However, if we are drinking but it's not happening, who wants to continue to drink wine or continuously take tequila shots and have that taste in their mouth, but they're not getting that pleasurable feeling? And it probably will reduce those cravings because that pleasurable feeling is not happening. Acamprosate or Campral is another one that can be used, and it is thought to reduce symptoms of protracted withdrawals such as insomnia, anxiety, restlessness, dysphoria, any kind of unpleasant emotion or uncomfortable emotional states. We're looking at also depression, anxiety, or irritability. It may be effective with clients with a severe dependence on alcohol. So that is something to consider. And of course, when we are considering, when I say we, just the overall medical field, well, mental health as well as medical field, what's very important is let's look at how long this person has been on alcohol, the intensity, the duration, and as well as the type. So that's all of that's important. Topiramate or Topamax is also used, and this reduces cravings and withdrawals, as well as it increases days of abstinence and overall recovery. So if it's reducing those alcohol cravings for a person with alcohol dependency as well as the withdrawals, this is also very beneficial. Finally, antidepressants such as Prozac and Zoloft can be used in treatment of alcohol dependency. These SSRIs are helpful and may reduce alcohol use with clients that have a co-occurring affective disorder. So that is something else to consider. And let's say that we find out that when we are trying to figure out with the co-occurring disorder, is it depression or is it the substance abuse? Kind of like which one came first. And we realize that the client, just through our sessions, has been feeling they've had signs of or symptoms of depression, and it eventually led to them self-medicating. Then what we might look at as opposed to the antabuse and things like that, even though that substance abuse is there, we might try them on the antidepressant first, because what might end up happening is, besides it reducing, the use of alcohol, if those depressive symptoms reduce, then it could also just by consequence, reduce their need to self-medicate. Now, addressing opioid dependency, certain medications like methadone or dolophine, Sabrenafine, which is the trade name Subutex, naltrexone or Rivia. Some of these kind of treat the same symptoms of opioid dependency. And with these medications, acting in the same targets in the brain as heroin and morphine, these medications suppress withdrawal symptoms and relieve cravings. The naltrexone works by blocking the effects of heroin and other opioids at their receptor sites and should only be used in clients who have already been detoxed. Because of the compliance issues, naltrexone is not widely used as the other medications. All medications help clients disengage from drug seeking and related criminal behavior and can become more receptive to behavioral treatment. So that is just something else to look at, is that once we get those behaviors of the drug use, and we can reduce that, then of course they're more likely to be a little more receptive to treatment. So once again, with the methadone, the buprenorphine, and as well as the naltrexone, these are all kind of used interchangeably when it comes to treating the opioid dependency. But then there's other ones such as sometimes it's called long-acting analog methadone or L-alpha acetaminophene. But with this medication, it has similar properties to methadone with a slower onset and a longer half-life. It can be administered 3 times a week, whereas opposed to methadone is administered daily. The next one is naloxone or Narcan. Prevents or reverses the effects of opioids, including respiratory depression, sedation, and hypotension. It can shorten the withdrawal periods and also intensify the withdrawals. And this is pretty much so based on the severity and the duration of the withdrawal syndrome, which are related to the dose of Narcan and the degree and type of opioid dependency. So it's a very intense and serious drug, and although it may shorten the withdrawal periods that a person is having when they're coming off of an opioid, those withdrawal symptoms can be very intense. And when it's administered to a patient, it's really not known how intense those withdrawal symptoms might be, because we have taken into consideration, the physician might be able to administer a low dose, but then when we look at the degree and then the type of opioid dependency that person might have, the combination between those two, those withdrawals can be short and pretty stable. They can be short and very intense. So with that one, I would say just personally it's a very intense medication. Nalfem, excuse me, Nalmefene or Revex is our final one we will look at under opioid dependency. And with this medication, it works by blocking opiate receptor sites, which reverses the or prevents toxic effects of the narcotic, especially in the case of an overdose. And I have seen in some cases where, it's only been on TV when you watch those shows like Investigative Discovery or Drugs Incorporated. But if a person is having a heroin overdose, the show I did watch where first responders did give the person right there on the street the Revex because they were overdosing, their body was convulsing, and that is to quickly counteract that heroin in which they were overdosing in. So it's more of a counteractive to a person who has overdosed on heroin or any kind of opioid. Cocaine dependency. Tricyclic antidepressants have been very effective in reducing a client's craving and improving abstinence. Bromocriptine, or trade name Parladel, pretty much so is effective due to it being a dopamine agonist. It reduces cravings and discomforts in the early stages of cocaine withdrawal. So if a person perhaps is going to a detox center or just hospitalized, they might give them this when they're going through their early stages of withdrawal. Ibogaine is actually a root that is found in Africa, and what they found with the ibogaine shrub is that it masks cocaine in the opioid withdrawals. However, one of the other issues is it can cause hallucinations. Methylphenidate or Ritalin can also be used for cocaine dependency, and it reduces the cocaine relapse in clients, especially clients with ADHD. And finally, buprenorphine or Subutex is a mixed opioid agonist and antagonist, so it has both of those components, and it's used to treat moderate, acute, and chronic pain during detox, as well as long and short-term opiate replacement therapy. So as you can see, even with the buprenorphine, it can be used besides with cocaine dependency, opioid dependency. Bupropion, and as we look at like the Wellbutrin RX or Zyban, has been used to treat nicotine addiction. It has been effective, especially when there's a co-occurring condition such as depression. And keep in mind, nicotine dependence also has a high comorbidity, and not only with depression, but conduct disorder and ADHD. So we have to look at perhaps other medications that might be beneficial to the client. Another medication that is relatively new that's out there is varenicline or Chantix. And I'm sure you guys have seen the commercials on that. And this has been shown to block the nicotine, and which cannot activate those receptors. The receptors that are being blocked, and this is just the FYI on what they're called, are the 5-HT3 receptors, but really in layman's terms, they are the pleasure receptors. So if this medication is blocking those receptors and the nicotine is not getting there, it results in the reduction of nicotine as a reinforcer. Finally, we look at another dependency such as sex addiction. And SSRIs, in some cases, have had a side effect of reducing a sex drive. So possibly SSRI is a medication that can be prescribed for an individual with a sex addiction. The fourth and final phase of treatment, what we need to look at as clinicians is we need to assess the client's progress to determine if more attention needs to be paid towards the substance abuse or mental issue. Because we must keep in mind that when we're treating the primary mental health diagnosis with medication, they must not, or when I say they, we must not compromise the client with a history of a substance abuse. So, like for example, if and when I say clinician, so maybe if I will not say we because we will not do this, but if a clinician is likely to see an abuse of benzodiazepines, then we might have to take that into consideration if that's what they are taking, or even to suggest it, or if we know that they're taking it to address the issue, because we know that benzodiazepines can have an addictive quality, and if we know that this client has a history of substance abuse or is currently abusing a substance, and their physician might have prescribed them that, or the client might be considering it, that is something that we might want to talk about the client, about the client. Excuse me, I'm tongue-tied. Talk with the client about. It is always important to always monitor the chemical dependency issues, to monitor if they're still using, how often they're using, like I said, if there's any medications that were prescribed to them that they might be using. So it's very important for us to monitor those things, as well as be aware of support groups that are out there. As clinicians, we need to be sensitive with respect to clients whom might refer to Alcoholics Anonymous or Narcotics Anonymous groups. As clinicians, we should also inquire about the group composition and send clients only to groups that are sensitive to the medication issue. So besides the awareness of support groups, be aware of perhaps, and that doesn't mean you have to do thorough research on them, but just to make sure that if we do refer the client to that group, that it is going to meet their needs. And to prevent relapse, we might have to have a booster session or a stress reduction group. So those are those sessions, those in-between sessions we might have to have in order to reduce relapse. Finally, we need to have a clear plan on how to resume treatment. Sometimes our clients might relapse, and as a clinician, we should have a clear plan for resuming treatment without a heavy emphasis on failure and that, oh my gosh, you fell off the wagon, all is lost, because sometimes our clients might have that feeling. So that if they do relapse, there is a plan so that they can rework their program without shame and strive towards full recovery.